Hi, everyone. Thanks for joining us today. My name is Diane Johnson. I'm a clinical pharmacy practitioner at the William S. Middleton VA Hospital in Madison, Wisconsin. I'm joined today by Dustin. Do you want to introduce yourself?
Yeah, my name is Dustin Carneal. I am a clinical pharmacist at Aurora Baycare Medical Center in Green Bay, Wisconsin. I just relocated to Wisconsin after practicing in Northeast Ohio at a surgical specialty hospital.
Great. Well, we're very glad to have you here in Wisconsin, Dustin. Today we're going to talk with you about taking the pain out of managing acute pain in the opioid experienced patient. Neither of us have financial relationships to disclose. And the learning objectives by the end of our time here together today, we will have reviewed current guidelines for management of acute pain and how they apply to the opioid tolerant patient. We will explain the role of opioid and non-opioid medications and treatments in the management of acute and peri-operative pain management and apply them to a patient case. And we'll appraise strategies for implementation of a pharmacist-led pain management protocol. We've got a couple of patients we want to introduce to you today. First, we have KS, who is a 45-year-old with a past medical history that includes a traumatic amputation of the left lower extremity following a motor vehicle accident about 15 years ago. KS has been on opioids since that time, but has not increased the dose in the past 10 years. KS recently tore her rotator cuff and is planning on surgery after an inadequate trial of PT. Currently on fentanyl 50 micrograms per hour patch applied every 3 days, oxycodone immediate release 10 milligrams every 6 hours, averaging 30 milligrams a day, some gabapentin, some duloxetine. And we have EA, who is a 65-year-old with past medical history of opioid use disorder and has been using buprenorphine naloxone product for the past 8 years. He's planning a total knee arthroscopy in the next few months, arthroplasty, in the next few months, and is fearful of high pain levels that could lead him to relapse. Currently using Suboxone, which is the buprenorphine naloxone, 4 milligrams twice a day. Acetaminophen or Tylenol, 650 milligrams 3 times a day is needed. Ibuprofen, 600 milligrams 3 times a day, lisinopril, and sildenafil. Of note, there's an error on this slide. It's not the Suboxone naloxone, is buprenorphine naloxone, and it's not PO, it's sublingual. So sorry about that. Not a trick question here. All right, moving on. We're going to talk a little bit about acute on chronic pain. So what is this? So you've got chronic pain at baseline in a patient who presents with a new pain complaint. So some examples of this could be a patient who has chronic pain who gets diagnosed with cancer, who has trauma, either planned or unplanned surgery, or a change to the disease process. So let's think about these patients. Who has anxiety when you think about these patients? I know I do. This is really tough. You have to factor in all of their medications that they're taking and how that's going to affect their ability to manage the post-op pain. And then at your facility, who manages these patients when they present? Do you have an acute pain service? Is it the emergency room physician? Do you have a pharmacist on staff that's trained with a pain team? Pain nurses? So we're going to go into pain management here in the peri-operative period. So just general guidelines here. We've got these 3, which are pretty common guidelines for the opioid naive patients. We've got the Washington State Agency Medical Directors Group Supplement, the Johns Hopkins Prescribing Guidelines, and the Michigan Opioid Prescribing Engagement Network, or OPEN. So these guidelines have recommended number of tablets or recommend number of days that you're expected to treat using opioids for a surgery or surgical procedure. So keep in mind that these are all for opioid naive patients. And then we have the 2016 American Pain Society guideline recommendations for the management of post-op pain in patients that are receiving long-term opioid therapy. So this previous slide talked about opioid naive patients, and this is a little bit of a blurb about our patients who are on opioids prior to surgery. So the recommendations include this peri-operative evaluation, ongoing education, And then the third bullet point is recognize that post-operative opioid requirements will typically be greater and that pain might be more difficult to control. That doesn't inspire confidence in me. It's not giving me a lot of tangible information to go off of. It's just telling me, yep, you're right to be anxious about this one. And then again, consider the specialty consultation. I just asked you who at your facility does this. So if that's you, here we go. We got to figure this out. And then, of course, non-pharm interventions, non-opioid interventions, and then get some local anesthetics on board or PCAs when possible. Digging into the guidelines just a little bit more, I'm not going to go through all of these, but I pulled out the ones that I feel like are most pertinent to the pharmacist. So recommendation number 1 is regarding providing education. This is something that we are poised to do. We can meet with the patient. We're really great, and we have really great rapport with our patients. So providing that education is going to be something we can very easily incorporate. Recommendation number 3 includes clinicians conducting a peri-operative evaluation. So you want to assess the medical and psychiatric comorbidities, the medications that they're on, chronic substance abuse history. When we read through this, it's like telling you how to run a pre-op visit. So again, something that we can easily incorporate into our practice. Recommendation 6 is talking about multimodal analgesia. I just mentioned that as well. And so we want to use all of our medications possible to help management of pain. And hopefully this allows us to decrease the doses and maybe you lower the risk for side effects. Recommendation number 7 is regarding use a TENS unit or a transcutaneous electrical nerve stimulation. Note that you can't use this on very many chest surgeries in people who have a history of seizures or who have like metal. You don't want to use it over any sort of metal implant. Number 15, the panel recommends that clinicians provide adults and children with acetaminophen and or NSAIDs. And this goes again with the multimodal analgesia for number 6 is just giving you more specific medications to use. Number 17, again, more specific about using an NSAID. Number 17, here it recommends gabapentin or pregabalin. I'm going to go into in a little bit how this, since this 2016 guidelines, it's fallen out of favor a little bit, but it is still something that you could consider. Number 18, we've got 18 and 19 are both more advanced options, IV ketamine and IV lidocaine, which you typically need a more specialized provider or facility to be comfortable with these recommendations. Then number 20, again, anesthetic infiltration. So again, you would need probably an anesthesiology or the surgical provider help with that, but it's a recommendation that you could certainly make to them. Number 23, again, with the anesthetic techniques. Number 29, this one is interesting. The panel recommends that facilities in which surgery is performed have an organizational structure in place to develop and refine policies and processes for safe and effective delivery of postoperative pain control. What Dustin's going to go into later really targets this recommendation of number 19, and we hope it provides you some good way to talk to your facility and how you can incorporate this, and we can really target this recommendation number 29. So number 30, again, have access to the consultation with a pain specialist. That could be you after doing this presentation with us. Then number 32, I put this on its own slide because again, we're wrapping back around to that education. So all patients and their caregivers need education on the treatment plan and that plan for what you're going to do after discharge. So I mentioned the specific recommendations on those 3 guidelines, the Washington State, the Michigan Open, and Johns Hopkins, to give you explicitly how many tablets of opioids to give to a patient and how many days that you're going to treat the pain. And then I mentioned the APS guidelines don't give standard for specific discharge prescribing. It just says you will need higher doses. So what's important here is that patients will need individualized specific plans. I've had people ask me, oh, do you have this written down? What do you do in this case? And you can't necessarily provide a one-size-fits-all in somebody who is opioid experienced or taking opioids at baseline, because everybody's going to be a little bit different. What are their risks? What other medications are they taking? Do they have caregivers? So other disease states that they have, so other factors. So it's hard to do this one-size-fits-all. Dustin is going to go into how we can make this easier, but just keep in mind that these are the patients that we're really going to be helpful on for the team. So what I do recommend is to continue the chronic opioid regimen throughout the surgery or peri-op period if they're going to continue the opioid long term. If they're having a procedure that is going to improve whatever pain that they're taking their long-term opioid for, then you might want to start that taper earlier, either pre-op or during the peri-operative period. But if not, then there's really no reason to discontinue it completely. It is recommended that we taper back to this baseline chronic opioid therapy within 6 weeks of surgery. 6 weeks probably seems like a long time. When we look at our opioid recommendations for the naive patients, it's up to like 14 days of opioids. So they're expecting pain for 2 weeks. And here I'm telling you on these opioid experienced patients, you might have higher opioid requirements for up to 6 weeks. So we do need to give ourselves and our patients a little bit of breathing room. We don't expect them to be back to their perfectly how they were within that 2-week time period. So just keep in mind, we have a little bit of breathing room. And when we're giving the opioid prescriptions, just keep in mind that prescriptions will have a higher amount than you're typically seeing with the opioid naive patients. So just a couple of more concrete recommendations for you here. So the APS guidelines recommend NSAIDs. They specifically call out celecoxib. And as you remember, we like celecoxib because it typically has a lower bleeding risk. It's also been more studied in this, so I think that's how it gets this recommendation. And so it has been associated when given immediately prior to surgery with lower opioid requirements after surgery. So that's pretty great. This would be a little bit tricky because it would be done in the PACU or wherever your patients are immediately before going in for surgery. Keep in mind that NSAIDs are contraindicated for perioperative pain in patients undergoing CABG, and then again for that 14 days after, due to that increased risk of cardiovascular events. I personally don't like NSAIDs in any patients with heart disease. So it says within 14 days, I probably personally wouldn't use them for these patients unless there was really a compelling reason that we had to. Typically, NSAIDs are avoided in complicated spinal fusion procedures. Most of the time, the orthopedics are fine with using NSAIDs. I think they don't necessarily think that it's going to impair bone healing for most procedures, but with surgical fusions, I've seen them say 3 months without NSAIDs. That can be kind of tough for patients who were really relying on their NSAIDs, maybe for their other arthritis joint pains. And then studies have shown no difference with using NSAID versus not using NSAIDs for hematomas, return to emergency room, or blood transfusions when used in the post-op period. So that's great news. So we know we can use NSAIDs relatively safely, barring other contraindications. We recommend Tylenol, which is available PO and IV. And then the gabapentinoids, which I recommend referenced in the APS guidelines. However, a recent meta-analysis in 2020 showed no clinically significant impacts. So if you feel like the patient has another indication for a gabapentinoid, go ahead and use it. But the data is certainly mixed if you want to use it as part of a protocol for all patients. A little bit more into our specific multimodal therapy. I feel like everybody is pretty familiar with IV ketorolac. It's been our workhorse for what feels like forever. It's indicated for short-term management, which is defined as up to 5 days of moderate to severe pain. I've got the dosing here, which you're familiar with. Interestingly, 15 milligrams is not significantly different than 30 milligrams as far as clinical effect when in trials. So going above that 15 milligrams IV dose is not necessarily beneficial. So we can lower that dose to minimize the risks. And also here, there is studies that show that 30 milligrams of IV ketorolac is approximately equivalent to 10 milligrams of morphine. And so that's just sort of your equal analgesic when you're deciding how much do I want to use. And then of course, the studies show there is a bit of an opioid sparing effect. So that's great news there too. When you can minimize the morphine, so you're gonna have fewer opioid side effects as well. IV meloxicam is the new kid on the block. It was approved just a few years ago, back in 2020. It's indicated for adults, the management of moderate to severe pain alone or in combination with other NSAIDs. What's really great about IV meloxicam is that it's a once daily treatment. A patient could present to the clinic and could have it done there. So that's sort of a unique piece of it, is since it's just the once daily, or for patients who are maybe averse to getting injections, but need the IV medications. It's not recommended for rapid onset because it does have that delayed onset. Patients must be well hydrated, and that's in the package insert, to avoid kidney injury. Again, contraindications, not surprisingly, cabbage, aspirin, or volume depletion. Ibuprofen is another option we have. It is 3 times a day, administered over 5 to 7 minutes. So both the meloxicam and the ibuprofen don't have that 5-day maximum recommendation like we do see with ketorolac. So that is certainly a benefit of these if you have a patient who has a longer need for multimodal treatment. It's again contraindicated with cabbage, and the side effects are similar to placebo without an increase in bleeding rates. IV acetaminophen is for mild to moderate pain or management of moderate to severe pain as an adjunct to opioids. So that's a little bit different with this one. It can also be used for fever reduction, of course. Dosing most common we see is the 1,000 milligrams every 6 hours. It's administered IV over 15 minutes with a max of 4 grams per day. Interesting that the Cmax is 70% higher than oral, and I remember going to a drug talk on IV acetaminophen many, many years ago, and they were really proud of that. But if you read the fine print, the AUC is similar, so maybe it gets you to the peak faster, but the area under the curve is similar. So very similar in effect to PO acetaminophen, only the benefit is that you can give it to somebody who's NPO. Obviously contraindicated with severe hepatic disease, and very minimal side effects. I don't know if you've heard of the Enhanced Recovery After Surgery, or ERAS protocol. These are numerous guidelines that are available for a wide variety of surgeries that are designed to achieve early recovery for patients. The focus is not necessarily on pain management, although we do acknowledge that improved pain management gets people mobile faster and discharged from the hospital sooner. So there's specific recommendations for various surgeries in regards to pain management. So I've highlighted a couple here for total hip and total knee replacements. They recommend smoking cessation. This helps with bone healing after surgery, and the studies do also show that people who smoke have more pain than people who don't. So again, it is a great recommendation for all of our patients who have pain. The routine use of NSAIDs is recommended for those without contraindications, which is great because I just went through all that with you guys. And that opioids may be used when required as part of a multimodal approach. I feel like this is helpful. We get a lot of data thrown at us about how we shouldn't use opioids in our patients, or we need to minimize opioid use. So it's nice to have people telling us, no, it's okay. There are definitely times when opioids are appropriate. I'm not going to go into this too much, but I did mention ketamine and lidocaine as some of the recommendations from APS. So here's some information for your reference if you're interested in taking this back to your facility. I would recommend that you get protocols written, and the nurses will need to know what to monitor for. So some nursing orders would be helpful as well as they're administering these medications. So let's catch up with KS. He was our 45-year-old that had the history of the traumatic amputation on the fentanyl patch. So we just went through several multimodal recommendations. So just thinking about what we could offer for our patient KS. So we know, being on opioids prior to surgery, that she is going to have higher opioid requirements post-op. We know that her pain will probably be worse than average, and then it might take up to 6 weeks for her to get back to her baseline pain. We do not expect that the shoulder surgery is going to improve the chronic pain she has from the amputation site. So there would be no reason to initiate a rapid taper or plan to taper in the perioperative period. If we could taper her well before surgery to get to the lowest dose possible, that will certainly decrease her post-op opioid requirements. But again, this could take a couple of months planning, and we'd want her to be agreeable to that. And then we would employ all of our multimodal treatment that we just went through. So a summary of the recommendations that we have for multimodal therapy to reduce opioid requirements or for those that will have high opioid requirements. Now we're going to transition from our patient who's on fentanyl for pain to our patients who have opioid use disorder. So question for the group, should buprenorphine for medications for opioid use disorder be stopped prior to surgery? Or what can be done with that buprenorphine dose? So I want you to think about that as we're going through the next few slides. This is just a refresher for you. So this is the sublingual dosing of buprenorphine, 2 milligrams versus 16 milligrams versus 32 milligrams. If you can see here on the lower doses, you do have a substantial amount of mu opioid receptors available. As you get up to 32 milligrams, there's very few mu opioid receptors available. So what this means is that if you try to give somebody a classic opioid like oxycodone on top of somebody who's on 32 milligrams per day of buprenorphine, it doesn't really have anywhere to go. It's not going to act on those receptors or be very effective. So keep in mind that the dose does matter with how much buprenorphine a patient is taking and what we're going to be able to do with opioids on top of their buprenorphine dose. This slide is very difficult to read, and I don't intend to go through it with you today. I share this because there's some really excellent references out there that there weren't even a couple of years ago on how to manage buprenorphine in the perioperative period. So this is recommendations from the American Society of Regional Anesthesia and Pain Medicine from 2021. And it talks about what to do with buprenorphine, how to add on other opioids, non-pharmacological and non-opioid recommendations, very similar to what we went through, was just putting it all nicely in one place. So when you get the patient that comes in on buprenorphine, we don't have to panic. We don't have to have those high anxiety levels. We'll just review this chart and see what we can add on for our patient. This is also from the American Society of Regional Anesthesia and Pain Medicine. And it is talking about what to do for how to initiate buprenorphine in the perioperative period. And so this would be for your patient who has opioid use disorder, comes in for an acute pain, and you decide they're appropriate to start buprenorphine for MOUD, and they agree to it. So this would be how you get through the perioperative period. Again, I'm not going to go through it with you, but it's a great reference for you to come back to when you have this patient case. This is a great algorithm from the anesthesiology in 2017. It has this chart on what to do if you've got patients presenting on buprenorphine for an emergent or urgent surgery. Minimal to no pain. If they're still taking their buprenorphine, again, talk to the surgeon or anesthesiologist, and we do recommend continuing it. Now, if you've got a patient coming in with moderate to severe pain and they're still taking the buprenorphine, these would be where you have to have those discussions with the patient. In most cases, if they're going to have high opioid requirements, we recommend discontinuing the buprenorphine. And of course, prior to doing this, you do want to talk with the patient and make sure they're comfortable doing that. If possible, talk to their prescriber. They probably know the patient better than you. You need to think, is this going to be safe for this patient? How can we handle this situation? But typically, if they're going to need those they're on a high dose of buprenorphine, they're going to need opioids. There's very few of those mu opioid receptors left, so your really chance is only to discontinue the buprenorphine. And so in that case, you do the same multimodal treatment. You do want to keep in mind that in opioid tolerant patients, they're going to need higher doses than you're used to seeing. We can't assume somebody is drug seeking just because they need higher doses. So let's catch up with EA. He is the 65-year-old who is on our buprenorphine naloxone. So he's nervous about this because he doesn't want to be on opioids because he's concerned for a relapse. So if we think about the dose of the Suboxone that he's on, 8 milligrams a day, he's still got a good amount of mu opioid receptors left. So in a case like this, we would want to continue the buprenorphine through the perioperative period. Anesthesia is aware and they can use other techniques. We would probably want to do a nerve block or find some other multimodal techniques to help decrease the opioid use and be sure that he's comfortable, knows what to expect. lot of education going to it that, yeah, he's going to have higher pain levels for a period of time, but we're going to be right there with him and we're going to be sure that we're taking his pain seriously. I'd probably also give him a naloxone kit. Methadone is also a medication that we use for MOUD. There are some nuances with it. Outpatient methadone for MOUD has to be done through opioid treatment clinics or opioid OTPs. However, inpatient physicians can legally order it when the patient is admitted primarily for other reasons. So for our patients who are admitted for acute pain, the inpatient physicians can't order their methadone dose. We do recommend that you contact their treatment program to confirm the dose, when they last took it, how many doses they might have. In Madison, our clinic is closed on Sunday, so a patient gets a take-home dose on Saturday. Many years ago, I was doing an admission med history. I was in the patient's room, and he pulls his Sunday dose out of his pocket, says, "Oh, can I take this?" I'm like, "Oh, well, no, but thank you for sharing this with me." So that was pretty easy. Then I could actually confirm the dose and where his treatment program was. We had, unfortunately, we had to dispose of that, and we would give him our hospital supply. So patients, we need to remember that patients in pain should receive their full usual daily dose of methadone, barring contraindications. Obviously, if they're sedated or having opioid side effects or other reason that you wouldn't want to give them an opioid, you wouldn't give it. Something we can do is consider splitting the daily dose. So similar to like we do for buprenorphine, where if they're on the higher doses, instead of that twice a day, you could split it to 3 or 4 times per day to sort of even out or smooth out the mu opioid receptor activity. We can do that with methadone as well. Typically, OTP programs are once a day. So you could give the same total daily dose divided, and that can help with acute pain management. And so we also need to remember that patients will need pain medications in addition to their usual dose. We can't assume just because, oh, he's on methadone, he's covered. No, that just keeps him level. So when he has acute pain on top of that, he is going to need higher something. And so whether that's like splitting the daily dose, increasing his methadone, or just ensure that the PRN dosing is adequate. I would hate to see somebody that's on 100 milligrams of methadone a day through their OTP getting 5 milligrams of oxycodone TID PRN. That's not going to cut it. And then the patient's going to complain that it's not working, and then people are going to assume they're drug seeking. So we just want to avoid that altogether and be sure they're getting adequate doses, which, as APS tells us, expected to be higher. So this is just a chart that I found that really helpful. So again, talks about what you should do with the methadone. So continue it, like we talked about earlier, and then arranging for follow-up with the methadone provider in the post-operative period. So we need to coordinate when they can get back to the clinic. This could be very challenging for a patient who may have limited mobility or limited access after the discharge. So prior to discharge, it would be good to have a plan with how the patient is going to resume their methadone maintenance treatment. For me personally, naltrexone is the scariest. If somebody is on naltrexone, it blocks the opioid receptors. And typically for patients with opioid use disorder or alcohol use disorder, if we can plan, let's stop the naltrexone pre-surgery if the surgery will require opioids. 72 hours for the oral or 4 weeks or so for the injection. And again, if they're on the injectable, consider giving them oral tablets to bridge until that 3 days prior. We need to remember in patients that use naltrexone, they might be more sensitive to opioids than average. So there's opioid receptor upregulation due to the chronic naltrexone use. So therefore, you'll see greater effects from lower doses of opioids than previously used. This is counterintuitive to our opioid experienced patients. And I included this because personally, like I said, these patients give me anxiety and how to manage their pain. So I wanted you guys to have the reference for this as well. And then have a plan for the naloxone reinitiation when out of the post-op period. You have to have a washout of the opioids. So they're going to have this brief period of time where they don't have anything. And so ensure that patient has the support they need. So again, a similar chart that can tell you how to manage the naltrexone. I'm sorry, I said naloxone, naltrexone in the perioperative period. All right, now I'm going to hand it over to Dustin.
So now we're going to look at what is our pharmacist's role in managing this acute pain. What if this is something I see as an opportunity at my hospital? Where does a pharmacist fit in? How do you go about implementing these recommendations? We want to look at the very beginning of where a patient may start in a perioperative window. What does that patient interview look like? We want to identify their actual medication use. We'll look at their prescription monitoring. Are they taking more? Are they taking less? Are they taking some of their friends' medications because the pain is overwhelming? And identify what that is so we can see what has worked, see how they cope with the pain, and assess those 5 days of pain management and really identify each piece that's important for them, what their goals are, their activities of daily living, what they expect pain to be like, and what has worked and what hasn't in the past for them. And there's a great way to help classify patients for this assessment. What we want to do is not only look at their opioid use, but what risk factors are there for adverse events? What kind of modifiers exist? Do we want to look at our opioid-naive patient that wouldn't need any pre-op medications that we want to try and minimize opioid exposure altogether? Our opioid-exposed patients who, have taken medications in the previous 90 days that we can be a little less aggressive on opioids and to think more about our non-opioid medications specifically. But with each patient, there's also the pieces that make us put patients more at risk of adverse events. And maybe it's uncontrolled psychiatric history. Are we looking back at refill history of medications or behavioral tendencies? When they have pain, do they borrow or take more of what's prescribed? And understanding that so we can address the patient with shared decision making. In the preoperative area, we want to go and look at, in this preoperative admission, we want to have that shared expectation, setting the patient and the caregiver those expectations of what do you think the surgery will be like. I can't explain how many times I've seen patients in a preoperative visit and asked, what do you expect your pain to be postoperatively? And they said, well, the surgery is going to fix my pain, so I will have no pain on the day of surgery. And really, we're causing an injury to fix a long-standing injury. And that is something that is going to cause pain in different ways. We want to calculate their oral morphine use per day and stratify them based upon those risks of complications. We want to address those modifiable risks and plan for, are we going to taper their long-acting opioids? Do we need to reach out to a provider? When we look at those modifiers, maybe we address those patients in different ways. If they're opioid naive, we can stratify them to fit a protocol, and we'll walk through an example later. If they're opioid exposed and have multiple risk factors, maybe we don't target as high of certain doses of medications to mitigate any adverse effects. This is what that risk stratification optimization looks like. And each patient needs that understanding of shared education of what that multimodal analgesia is, what the expectations are for surgery, but I also want to make sure we address the psychosocial comorbidities before surgery. There's no study that shows that treating or managing psychosocial characteristics improves perioperative pain. However, we want to make sure we understand that there are complexities of overcoming accompanying disorders of depression and anxiety or PTSD, or look at medication use disorder as a whole to ensure that is well managed, and that is a piece that weighs heavily on patients in that perioperative period. When we look at our patient here for this risk, we have somebody who was in a car accident. They're on the chronic opioid. So we're going to make sure we manage that. The chronic opioids are not related to the procedure. But we also want to ensure that we have the rehab continuing. The patient has failed a trial of physical therapy, but we want to ensure that that strength and conditioning continues to minimize that perioperative pain, and understanding that discussion with the patient about postoperative expectations is important. We also can look at the psychosocial aspects of the duloxetine. Is the patient's anxiety and depression managed well? If they do have a lot of pain or complications postoperatively, how are they going to manage that additional anxiety as it comes to managing pain postoperatively? Are they refilling it regularly? Are they taking it as needed? And ensuring that we have a good plan for that as we go through the preoperative period, preparing for surgery. When we look at our 65-year-old here, who he is fearful, and he states that he is not on any antidepressants. So we want to ensure that that psychosocial aspect in the months leading up to his surgery are well maintained. We also can look at that tapering of the medications. Is that something that we can do preemptively, working with the provider? And that 6 weeks post-op that we are going to taper our acute management, what does that plan look like? We always want to plan for discharge in mind from the beginning. So then again, we look at preoperative education, psychosocial optimization, but then also those patients on high doses of opioid use disorder, we want to refer to their perioperative specialist, making sure they're aware of what's going on and what they have seen work in the past, and can continue and manage in that 6 weeks in the postoperative for that tapering plan. In the preoperative area, when the patient arrives for surgery, we want to continue to re-educate on goal and expectations. We want to have that shared decision making with not only the patient and the pharmacist, but also anesthesia and the surgeon. When we look at the collaborative communication of the anesthetic plan or analgesic plan, when we look at surgeries such as total hips and total knee procedures, and we also look at spinal procedures such as like a lumbar fusion, recommendations are from newer literature being published in the physical therapy environment. It shows that early mobilization is something that can improve postoperative pain control. Anecdotally, when working with one of our spine surgeons and our total joint surgeons, we identified that patients who are able to get up within 4 hours of surgery and they were opioid naive took no opioids on post-op day 1. And there's some complexity to that. Do we look at off-label injections such as bupivacaine spinal versus bupivacaine? Do we look at your adductor canal blocks? When you ask physical therapy, one of the biggest challenges is in the postoperative period is pain is uncontrolled, the patient is over-sedated, or the patient has numbness from a exparel block that lasted too long. So that shared communication of what is the expectation. And so when we see the patient in the preoperative period, we're going to say, your doctor's going to do surgery, and 4 hours after surgery, physical therapy is going to come see you. And it's going to be painful. It's going to be difficult to get up and walk to the bathroom, to get those steps in, but that is key to recovery. And knowing that the anesthesia providers are able to look at alternative anesthetic, analgesia, and block interventions in the preoperative space to ensure that timing of wear off is optimal for the pain needs and for looking at the physical therapy needs of ensuring they have the ability to work with therapy. We want to look at their oral multimodal analgesia. So are we going to provide PO Tylenol in the preoperative space? If so, how much? When we look at our gabapentin gabapentin, are we continuing the patient preoperatively, or are we not giving it because of risk of respiratory depression or sedation in postoperative period? That's where that complexity comes in. If a patient is already on it, are we going to continue it, or because of respiratory depression risks in that perioperative space, are we going to hold it or dose reduce it due to age or renal function? And the key here is we're going to continue our chronic long-acting opioid therapies on the day of surgery. And that is to ensure we can manage that baseline dose that the patient is already taking. So let's catch up with our patient. They're in the preoperative space. They have a fentanyl patch that they apply every 3 days. We're going to discuss that plan with anesthesia to ensure that they want to continue that as their basal needs to ensure we can, in the postoperative space, after the procedure, manage their pain. We're also, since they're chronically on gabapentin, we're going to check their renal function, ensure that they don't have any sedation, or they're chronically taking the gabapentin. Maybe they have side effects at home and they're only taking 100 milligrams instead of 900 3 times a day. We want to ensure that if they are on a consistent dose, we do provide that to them in the preoperative area. For our patient here with the Suboxone therapy, we could go and take the Suboxone therapy and spread it out. And take it and provide multiple doses per day. So the twice a day dosing, we can set it up as 3 times a day dosing. Take the total dose in the day and divide it up to provide more of a consistent dose. This is more often you see this need in someone who's taking Suboxone once a day, and we need to separate it. But it also works very well in patients taking it twice a day and splitting up into 3 times a day. The other location we see this, as Diane mentioned earlier, is with our patients on methadone. If they're taking one large dose, taking it and splitting it up to the same total daily dose, but in multiple locations per day. Our patient takes ibuprofen chronically. We would want to target utilization of a Celebrex and 975 milligrams of Tylenol in that preoperative area. And we're hopefully going to continue the antidepressant that we started in our preoperative visit. When we look at patients and pain and this is overwhelming, there is a way that we can stratify and set patients up in the postoperative and preoperative period to allow the surgeon set them up for success. We can make adjustments to a pain plan, but sometimes we don't want the provider to have a favorite order set and select the same 5 milligrams of oxycodone every 6 hours for every patient without assessing their opioid use at home. So if this is set up in the preoperative area as reviewing what the patient takes chronically and what their actual medication use is, we can stratify them to a standard level for that first preoperative area doses, and then also in the postoperative area. Taking into account the risk modifiers. So this is a draft example of what that may look like. So for a patient who may take 5 to 10 oral morphine equivalents per day, we may start them at a level 3 plan, just for sake of example. And that allows us to consistently manage initial pain or preoperative pain for those patients. Maybe they have modifiable criteria that make them at higher risk for adverse events. If that's the case, we may take them, instead of starting them at level 3, reduce them to a level 2, just for that initial period of assessment.
That way we can standardize what we can, but it's also a personalized way to approach the patient for each specific patient's needs. And protocolize what you can so the more complex patients, you have a little more time to address. Looking at our intraoperative and recovery space, it's continued collaborative communication. For patients who may be seeking an early mobilization need and providing bupivacaine, a shorter acting spinal, versus a bupivacaine, a longer acting spinal, they would need more of a opioid and have higher opioid needs in the PACU space. That higher opioid use in the PACU area, we want to ensure is addressed early so we're not behind the pain. And so providing that minimization of opioids in the OR, but also ensuring that in the postoperative space, we're addressing the opioid requirements based upon the type of anesthesia that they were provided. Patients who will have complex needs and we want to also minimize opioid use, we can also evaluate our utilization of infusions of lidocaine or ketamine. We also want to ensure that oral agents can be started as soon as possible. The risk of using IV doses can be critical in addressing pain, but may also have that more addictive property if given too often for a long period of time. So if a patient is healthy and able to take oral after surgery through minimization of postoperative nausea and vomiting protocols, we can try and administer and start our analgesic agents and multimodal agents in the PACU and recovery area as soon as possible to stay on schedule. So if you have a patient who received Tylenol in the preoperative area 2 to 3 hours before surgery, they had a 1 to 2 hour surgery, and they're now in PACU for 1 hour. We want to ensure that IV or PO Tylenol is available in that PACU area, not just our what we typically see at allotted every 10 minutes. We want to be able to start that postoperative plan as soon as possible. Postoperative, it's that continued reinforcement of preoperatively we discussed that, hey, you will have pain, those realistic expectations. We have the complex healing properties when it comes to surgery of inflammation, neuromodulation, and peripheral sensitization that we want to ensure are addressed in that healing process. Our analgesia and anesthetic plan, what we performed also can impact when that early mobilization can start. I know there are a lot of providers that love using Exparel for certain blocks. However, that long duration may impact the patient's ability to perform or participate in physical therapy. But we want to ensure that we're also standardizing that protocol. Discussing with various anesthesiologists and CRNAs, they a lot of times start and use their own cocktail of blocks. And having a standardized protocol can help predict in the postoperative period when those are going to wear off consistently. So the perioperative pain plan of opioids and non-opioids can adjust and work with the wearing off of these blocks. We want to ensure our dosing is appropriate. There's the expected pain response, and also ensuring we understand what the tolerance is for those. And if we're ensuring we meet the patient's needs initially, and matching what their home opioid use is to what our PRN doses are. Some say that our PRN or total opioid needs is 50 to 100% more than what is done at baseline. And that can be debated. We just know that the patients will need more narcotics. So we want to ensure that we are addressing the total dose and the frequency to what that baseline is. We're going to continue those chronic long-acting therapies, but also surgeries happen all time throughout the day. So we want to ensure if it's an early or late surgery, those chronic opioid therapies are timed appropriately to ensure that the evening dose is not skipped or and delayed until the next morning. So it becomes creating in that post-operative and when the patient is admitted to the floor, and timing those medications appropriately to prevent overuse and over sedation, but also preventing falling behind on the opioid needs. And as always, at the beginning of procedure, we're always talking about the discharge planning and the weaning of medications as it comes to the patient's progress. One thing I think is very important to establish when a pharmacist and multidisciplinary team is coming together to discuss peri-operative pain is sometimes we can use the terms of so-and-so's order set for pain never works. I always need to call. Or patients who have this type of procedure are always in pain. And ensuring that your organization develops a standard definition of when reevaluation occurs and what is, quote, a therapy failure. And I'll walk through this a little bit here. A therapy failure, I think, is a great way to define if a patient really receives a PRN medication for, let's say, severe pain. When do we determine that that severe pain dose is ineffective? And when do we want to allow breakthrough medication to occur? And this allows a consistent evaluation of those patients' pain needs. And this can, as you evaluate your PRN or protocol orders and develop these standard order sets based upon opioid use at home, the oral morphine equivalents daily, this benchmark can be used to provide protocol-driven change. So let's say a patient is receiving PRN medication and they're on your, quote, level 2, level 1 order, and you want to move to a level 2 order. When would a nurse need to call? What does that look like? Well, if our organization defines a therapy failure as a PRN medication for severe pain did not improve the pain score by more than 3, then if the nurse assesses that medication and they provide the severe pain dose of medication, and an hour later their score goes from a 10 to a 9, they can consider that a therapy failure, and reevaluation may be needed. But we want to ensure that multiple factors are in place. So when the next PRN severe pain order is available, and that occurs again, it goes from a 10 to an 8, that it may not be sufficient for your organization. And this is a great way to ensure standard review and evaluation of the pain orders. And this is something that my previous organization, we utilized and provided a lot of nursing education. A patient may be in pain, but what, based upon that shared decision-making, was a acceptable level of pain for that patient and that procedure. what was their benchmark level of pain? Is it something that we're still meeting, or are we now needing to adjust all the orders and not just provide that PRN dose of medication? So what I've seen utilized here is an example, a protocol-driven way to say, may convert from a level 1 to a level 2 if two therapy failures or PRN medications are not providing that improved pain score of 3 or more in the previous 10 hours. Their vital signs are stable, and the nurse can contact someone to adjust the protocol orders. In a patient who is on chronic opioids less than 60 oral morphine equivalents per day, this may be easy because you're able to go from a level 4 to a level 5 and provide an increase of not only just the severe pain doses, but an increase of your mild, moderate, and severe pain doses. This allows for an overall adjustment in a pain management plan and not just providing those once orders for Dilaudid that you may see, or just adjusting the severe pain dosing when if a patient's pain is now more well tolerated and managed, they may have moderate pain scores, and now the moderate pain doses are not effective in managing their acute pain. And as always, we want to ensure this is personalized based upon the drugs and comorbidities that are there with the patient. And this is what I say would be a good starting point for the physician to initiate standard order sets in the postoperative period, but also reassess consistently. And discharge and follow-up is always something we want to ensure we address at the start of any interaction with the patient with acute pain or with planned acute pain in a preoperative setting. We want to take that final 12 to 24 hours of opioid utilization. And this can be challenging when it comes to meds-to-beds programs where prescriptions are filled preemptively. If we have a standardized way of providing that level 1, 2, or 3 for a lot of patients, maybe that can be consistent in what our postoperative plan typically is for those procedures. But also ensuring that patients who are having a lot of adjustments in their needs, we have the ability for pharmacists to adjust that opioid prescription to less or more based upon what that opioid utilization is in that final 12 to 24 hours of hospitalization. And this goes for anything, not just peri-operative pain management, but all patients undergoing pain management in the hospital setting. We want to also ensure that there's follow-up and education plan. We look at our bowel regimens, education on disposal, naloxone prescription and education. But there's a complex interplay of all these different factors going on and ensuring not only the pain is well tolerated, but ensuring opioid abuse is not something that occurs in the patient's future or family's future to ensure they're properly disposed and overdose needs are met through a weaning plan and naloxone availability. And this is where we also want to ensure that weaning plan of that next 4 to 7 days, our initial follow-up is, and then over the 6 weeks, what that dose tapering plan looks like. So now, where do I get started? We talked about the pharmacist's role and all these medications available to help patients in acute pain. And really, we're not only just looking at perioperative pain, but we could be looking at somebody in the emergency department for need of pain management. We're just taking those assessments and moving them from planning to that initial patient interview occurring at the time of presentation. And this is looking at patients in our emergency department. The pharmacist in the emergency department providing these skilled interviews to ensure that our initial pain management plan in the emergency department and on admission is set appropriately. So we want to identify key stakeholders. I really enjoy working with physical therapy because they understand when a patient is moving, what their needs are to assess more of their activities of daily living. We have our baseline control, but what are the things that exacerbate that pain when it comes to movement or activities? We want to research where the current pinch points are in practice of highest need areas. So what surgeons are getting called the most? What patients have a high risk of readmission for pain management? What patients have delayed discharge? Is there a unit or area that has a higher naloxone utilization than the rest of the hospital? What prescribers or patients or nurses are requesting once orders for breakthrough pain? These are all things that you can run reports on and identify where potential starting points may be for a practice implementation. And the dreaded on-call calls, the surgeon that's called at 3 in the morning for peri-operative pain management and says, give them 2 milligrams of Dilaudid. Those are something that can be tracked, usually through the on-call service of, okay, you're trying to page what provider and what is the reason, and trying to identify through that on-call paging program of the patient is not in pain. That is something that can be recorded and then reported as a way to identify a need or area for pain management practice implementation. You want to develop relationships and trust of what stakeholders have interest in this improving. Is it anesthesia? Is it nursing? Is it finance because patients are not being able to be discharged at the expected time approved? And wherever possible, we want to standardize our breakthrough orders. Maybe this is something based upon the level of pain or opioid use, oral morphine equivalents that are used, that there's a standard dose that you use for your once orders. There's a definition for what a therapy failure is at your organization. So when adjustments are needed to your interventions, you have a strategic way to make those interventions. And where possible, implement clinical decision support. I think this is key for utilization of our medications like Ketorolac for patients who are greater than a certain age, have renal function, or a Tylenol. If they're greater or less than 50 kilograms, you provide the 1,000 milligrams or 650. If this is something that can be automated, this is a great way to ensure adoption of these non-opioid medications. Be flexible, but be clear in what those expectations are for the different roles. And then, as always, if you become the opioid pharmacist that is going to assist with these complex acute pain patients, what happens when you're on vacation? And cross-train. Collect data on what your interventions are and your value. How many patients are now being discharged on time? How many patients are being able to be seen in their first physical therapy appointment postoperatively without being turned away due to uncontrolled pain or due to numbness and tingling and unable to participate in therapy? And then bundle these services. The perioperative area is key for ensuring appropriate DVT prophylaxis, ensuring the antiplatelets are held or resumed in proper time for various procedures or patients with cardiac history, ensuring the antibiotics are appropriate for the type of procedure or patient's history of blood cultures or multi-drug resistant organisms. If we're able to combine these services, this interview in the preoperative area and interactions in the perioperative area, intra-op and post-op, can not only improve pain management, but also ensure that there's less infections, and also ensuring that patients are having less adverse effects such as bleeding or clotting in the postoperative area. And then also looking at therapy interruptions. We're providing this interview with patients who may have other medications on board for other chronic diseases. I think about a lot of our biologic medications that can provide immunocompromised states. And some of those medications have to be strategically held in the perioperative area to prevent infection or complication and ensure wound healing. So those interviews can be combined as a bundled service that can provide overall value for your acute pain management as well. So now let's look at our self-assessment questions. These are what allows you to obtain credit for participating in our presentation. The available postoperative guidelines provide recommendations for opioid-naive patients only. Therefore, they can not be referenced when presented with an opioid-tolerant patient. Is this true or false? In this way, they are false because these are utilized as a reference to ensure how much pain is expected following the procedure and a guide to be for the expected recovery time. Question 2. Patient presents to the emergency department following a ski accident, and there is determined to be lower extremity fracture, and patient is reporting 10 out of 10 pain. Patient uses buprenorphine for a history of opioid use disorder and reports good adherence and no recent use of illicit substances. Which of the following strategies should be implemented for acute pain management in the emergency department? And as we discussed, we did talk a lot about perioperative management, but what we want to do is for patients in the emergency department with that acute pain, we're just taking our timeline and moving it up and shortening it. So we want to address and identify what that patient is taking the buprenorphine, what dose and how long, is it consistent? And we want to, all of the above are appropriate interventions. Managing our non-opioid interventions, provide an ice pack for additional therapy. We want to look at our nerve blocks. Is it something where a lower extremity fracture may be assisted with an adductor canal block? And we want to contact the provider to ensure that if we adjust the dose or discharge the patient on an opioid, the outpatient provider is amenable to that recommendation, and the patient is in pain. And when in pain, acute pain, the opioid requirements are going to be higher. And so a one-time dose of fentanyl is appropriate. If this patient is taking buprenorphine once a day, we may take this dose and spread the same dose out over the entire 24-hour period. And so instead of, let's say, 16 milligrams per day, we can separate that out into a 16 milligram total daily dose over 3 administrations. Which of the following treatments is most likely to be effective for acute pain management in a patient that uses morphine extended release 3 times a day? In this case, it would be letter D. We want to provide the patient with an acceptable acute pain management opioid, such as hydromorphone. A lot of times we want to avoid codeine. And we want to add on a non-opioid analgesic as well for target that multimodal approach. And finally, our self-assessment question number 4, which of the following is a practice challenge for implementing a pharmacist-led pain management program? And the answer is E, all of the above. We want to identify our champion who's going to help assist in those changes. We do want to standardize things where possible. look at the clinical decision support for managing medications like gabapentin and Toradol to ensure the age and renal function protocols can be managed, but also standardize what is your treatment failure protocol going to be for those one-time narcotic administrations. What is our standard spinal analgesia or nerve blocks going to be for our provider, so we have predictable administration and wear-off effects for our patients. We want to educate everybody on the team regarding our service to understand where pharmacists can be most beneficial, and then gather data. Multidisciplinary teams all have different data that they're gathering and benchmarks, and we can assist in gathering that data to secure funding for these through improved discharge, improved assisting with physical therapy, which also assists with discharge, shorter PACU time, and those are all things that can assist in ensuring there is funding available for pharmacist-led pain management program. This time we want to thank you for listening to our presentation, and if you have any questions, feel free to reach out and contact us. Thank you very much for your time.